Amyotrophic lateral sclerosis, ALS, physical therapy interventions. The role of physical therapists in management of individuals with ALS and the extent of interventions provided vary depending on whether or not the therapist is working as a member of a team specialized in ALS care or as an independent or clinic based therapist. Additional variables include the availability of other healthcare professionals in the practice setting and the reason the individual is seeking physical therapy. Example specific ALS related problem versus a comorbidity problem such as arthritis. Restorative intervention is directed toward remediating or improving impairments and activity limitations. In the early and middle ages stages of ALS, restorative interventions are temporary at best because disease progression is expected and permanent loss of function and disability is likely. Restorative interventions in the late stage of ALS are for the most part directed solely toward remediation of impairments that result from other systems pathology. Example pressure sores, edema, pneumonia, atelectasis, adhesive capsulitis. Compensatory intervention is directed toward modifying activities, tasks, or the environment to minimize activity limitations and participation restrictions. In the early and middle stages of ALS, tasks or activities may be adapted to achieve function. As the disease progresses, increasing environmental adaptations will be necessary to maintain and promote function. In the early and early middle stages of ALS, preventative intervention is directed toward minimizing potential impairments such as loss of ROM, aerobic capacity, or strength, preventing pneumonia or atelectasis, and activity limitations. Beginning an early prevention program may alter impairments and maintain physical function temporarily, and may also improve well being and decrease fatigue, as well as the secondary effects of immobility. In the late, middle, and late stages, the pathology is more advanced and mobility becomes progressively restricted. In these stages, it may be extremely difficult or impossible to prevent impairments and activity limitations that are directly related to the nervous system pathology. Thus, the role of prevention is tertiary in order to mitigate the effects of pathology that lead to impairments in other systems. Example, educating caregivers about passive ROM, exercise program to prevent adhesive capsulitis in the shoulder. In general, the role of the physical therapist includes the following: promoting independence and maximizing function throughout the stages of the disease through restorative and compensatory interventions that address impairments, activity limitations, and participation restrictions. Promoting health and wellness in the early and early middle stages of the disease through restorative and preventative interventions, providing alternative means of carrying out functional activities with adaptive equipment and alternate methods for performing tasks and activities through compensatory interventions as the disease progresses. Minimizing or preventing complications through preventative interventions throughout the course of the disease, providing education, psychological support, and recommendations for equipment and community resources to assist in adapting to the disease progression. Owing to the individual variability of the disease onset, disease course, and disease progression, patients with ALS will present with unique and different sets of problems, thus, interventions will vary. As described earlier, interventions are directed mainly toward addressing activity limitations and participation restrictions because often the impairment causing the limitations and restrictions cannot be altered. However, in the early and early middle stages of ALS, it may be possible to direct treatment toward the underlying CNS impairments and perhaps postpone the onset of particular activity limitations. For example, a study of patients in the early stages of ALS, FVC equal or more than 90% predicted, and ALS FRS more than or equal to 30, who engaged in moderate load, moderate resistance exercises were found to have higher ALS FRS scores and SF36 physical function scores compared to a matched control group who performs stretching exercises. Patients and therapists must understand that any beneficial effects of any early prevention program will be short term and will not have an impact on the overall course of the disease. Much more research into the effectiveness of interventions for individuals with ALS is needed. In developing a POC, in addition to the patient's goals, the therapist must also consider the rate of disease progression, the extent and area of involvement, stage of the disease, respiratory and bulbar factors that may affect participation, timing of the intervention, patient acceptance and motivation, life support choices, availability of psychosocial support and resources. Some patients may view the need to use adaptive equipment such as an ambulatory assisted device or wheelchair as a definitive marker for disease progression and impending death. This may cause the patient to be hesitant to accept the recommended aid or device as a means of maintaining some aspect of control over the disease. The physical therapist will be required to maintain a balance between being realistic about what can be achieved and providing a sense of hope, not helplessness, when discussing intervention options. As overview of ALS disease stages and general intervention strategies is presented in table 17.3. Common impairments and activity limitations associated with ALS and their respective interventions are described below. Cervical muscle weakness. Progressive cervical extensor weakness will cause the head to fall forward, resulting in overstretching of the posterior musculature and soft tissues. This may cause bouts of acute pain or develop into anterior muscle tightness or a chronic cervical syndrome. Some patients will compensate for the forward head positioning by increasing lordosis as they attempt to maintain their posture during ambulation. For mild to moderate cervical weakness, a soft foam collar may be worn during specific activities. Soft collars are comfortable, usually well tolerated. However, where induced compressibility requires that they be replaced frequently. For moderate to severe weakness, a semi rigid or a rigid collar is prescribed. These are usually made of padded rigid plastic or leather and provide very firm support. Patients may find the collars very warm, may experience discomfort at points of body contact such as chin, mandible, sternum, or over clavicles, may feel pressure on the trachea, and may feel confined. Several types of collars are presented in figures, and the pros and cons of individual collar types are summarized in table. Amyotrophic lateral sclerosis disease stages and common intervention strategies, framework for rehabilitation for individuals with ALS. Some patients with combined cervical and upper thoracic weakness may benefit from cervical thoracic orthosis or a sternal occipital mandibular immobilizer SOMI. These devices provide greater support but are more expensive and heavy and may be difficult to don and off. For severe or intractable neck weakness, referral to an orthotist or for a custom made device may be necessary. In addition to wearing collars, individuals with cervical weakness may also benefit from taking frequent rest periods, supportive seating, such as high back chairs or recliners, tilt in space or reclining wheelchairs, elevating reading material, and education about good arm support for prolonged sitting, proper use of head rest when riding in a car, and ergonomic changes for work situations. It is important to note that when trunk weakness accompanies neck weakness, positioning for head support becomes more challenging. Stage early, common impairments and activity limitations, mild to moderate weakness in specific muscle groups, difficulty with ADL and mobility toward the end of this stage. Interventions: restorative or preventive, strengthening exercises, endurance exercises, active ROM, active assisted ROM, stretching exercises. Compensatory: Determine potential need for adaptive or assisted devices. Determine potential need for ergonomic modifications of home or workplace. Energy conservation. Educate the patient about the disease process, energy conservation, and supportive groups. Middle stage, common impairments. Progressive decrease in mobility throughout the stage, wheelchair needed for long distances, increased wheelchair use toward end of stage, severe muscle weakness in some groups, mild to moderate weakness in other groups, progressive decrease in aerial skills throughout stage pain. Compensatory, support weakness, assistive and supportive devices, adaptive equipment, sling, orthosis, modification to workplace or home, example install ramp, move bedroom to first floor, wheelchair prescription, education of caregivers regarding functional training, preventative, active assisted and passive ROM stretching exercises, strengthening exercises, endurance exercises, determine need for pressure relieving devices, pressure distributing mattresses. Late stage, wheelchair dependent or restricted to bed, complete dependence with ADL, severe weakness of upper extremity and lower extremity, neck and trunk muscles, dysarthria, dysphagia, respiratory compromise, pain. Preventative measures, passive ROM, pulmonary care, hospital bed and pressure relieving devices, skin care, hygiene. Compensatory, caregiver education regarding transfers, positioning, turning, skin care, mechanical lift. Dysarthria and dysphagia. In collaboration with SLP and nutritionist, the physical therapist can play a role in managing dysarthria and dysphagia by addressing the patient's head and trunk control and positioning in sitting. In addition, the physical therapist can reinforce the use of strategies for eating and swallowing, example chin tuck, the use of prescribed communication devices, and the need for food consistency modifications because patients are at risk for aspiration. Education of the patient, family, and caregiver is imperative. Upper extremity muscle weakness. Weakness of the upper extremities greatly affects the patient's ability to carry out ADL. There is a large variety of adaptive equipment available that may help the patient prolong function for as long as possible. Patients with a painful shoulder due to subluxation may benefit from a sling, similar to those used with patients following stroke with decreased tone. Although subluxation cannot be corrected completely, splinting of the wrist or hand may be indicated to prevent contractures or to improve the patient's function, such as the ability to grasp. The headmaster collar, types of collars, Aspen collar, Miami J collar, executive collar, and soft collar. Types of semi-rigid and rigid cervical collars. Collars without anterior neck axis, collars with anterior neck axis for tracheostomy. Shoulder pain. Individuals with ALS may develop shoulder pain and present with capsular patterns of restriction. Pain may be caused by several factors: abnormal scapulohumeral rhythm, secondary to spasticity or weakness causing imbalance that may lead to impingement, overuse of strong muscles, muscle strain, faulty resting position, glenohumeral subluxation, secondary to weakness or a fall. Depending on the cause of the shoulder pain, interventions may include modalities, ROM exercises, passive stretching, joint mobilizations, and education about proper joint support and protection. A 20% incidence of adhesive capsulitis in individuals with ALS has been found. Recommendations for managing the pain and decrease ROM include a protocol of an intra-articular analgesic and anti-inflammatory cocktail injection followed by a course of aggressive ROM exercises. Some patients reported an acute resolution of pain, whereas others reported improvements over 2 to 3 weeks. Respiratory muscle weakness. Education is extremely important. Patients and caregivers must be taught how to balance activity and rest and educated about energy conservation techniques. Patients and caregivers should also be educated about signs and symptoms of aspiration, positioning to avoid aspiration such as upper cervical spine flexion during eating, causes and signs of respiratory infection, and strategies for managing oral secretions, use of oral suction device or choking episodes, Heimlich maneuver, specific breathing exercises and positioning to optimize ventilation or perfusion matching may also be incorporated, although their effectiveness in ALS has not been determined. A small sample size double blind study randomly assigned 9 people with ALS to an inspiratory muscle training IMT group. Subjects completed daily IMT training sessions 10 minutes per person, 3 times per day. After 12 weeks of training, subjects in the IMT group demonstrated trends toward improvement in FVC, VC, MIP, and SNP compared to a control group who completed sham training, and gains in inspiratory muscle strength were partially reversed after an 8 week period of training cessation. Airway clearance techniques may be necessary when conditions that cause secretion retention, such as pneumonia or atelectasis, arise. To compensate for a weakened cough, the patient and caregiver may be instructed in the use of manually assisted coughing techniques or MIE. Again, the effectiveness of these techniques or device has not been demonstrated in ALS, but case reports have described the benefits from regular use of a mechanical insufflation device. Studies of cough flows and pressure during cough augmentation have found that manual assistance increase flow 11% in those who with bulbar ALS and 13% in those with non-bulbar ALS. MIE increase flow by 26% in those with bulbar ALS and 28% in those with non-bulbar ALS. The greatest improvements were in patients with weakest cough. High frequency chest wall oscillation has garnered some interest in terms of its applicability to the ALS population. High frequency chest wall oscillation is an external non invasive modality that transmits high frequency oscillatory pressures through the chest wall and thereby mobilizing secretions from the small peripheral airways and enhancing secretions, clearance, and gas exchange. HFCWO has been effectively used in patient populations in which secretion retention and hypersecretions are issues, example cystic fibrosis. A study comparing 19 people with ALS who used HFCWO to 16 who were not treated found that after 6 months, those using the device had significantly less breathlessness. In addition, those users with an FVC between 40% and 70% predicted had significantly less mean decrease in FVC and less breathlessness and fatigue. Lower extremity muscle weakness and gait impairments. Orthosis may be recommended to improve function by offering support to weakened muscles and the joints they surround, decrease stress on remaining functioning or compensatory muscles, conserve energy or minimize local or general muscle fatigue. Controlling knee impairments can often be achieved through an ankle foot orthosis, as such, addressing the ankle should be considered first. It is also important to consider the weight of the orthosis as individuals with ALS will have energy expenditure issues and it may be more fatiguing for the patient to ambulate with heavy orthosis than to ambulate without impairment being corrected. For this reason, a knee ankle foot orthosis KAFO is not recommended. Deciding between a commercially manufactured versus a custom made orthosis is certainly dependent on the patient's resources, but the rate of disease progression should also be considered. For an individual with rapidly progressive ALS and who is likely to use the orthosis for a limited time, a commercially manufactured orthosis may suffice. Solid AFOs are a good choice for patients who have medial lateral instability of the ankle with quadricep weakness. The fixed ankle position combined with quadricep weakness may make it difficult for sit to stand transfers, climbing stairs, and negotiating inclines. Hinged AFOs allow dorsiflexion and may be appropriate for the patient with adequate knee extensor strength with mild ankle strength loss. The type of ambulatory assistive device prescribed is dependent on the degree of proximal weakness, muscle strength, or instability, function of the upper extremities, the pattern, extent, and rate of disease progression, acceptance by the patient, and financial constraints. Again, weight of the device is an important factor to consider in decision making while also taking into account which device will ensure optimal function and safety. Wheel walkers which do not require the patient to lift the device are usually recommended. In general, individuals with ALS are rarely prescribed crutches. If crutches are warranted, Loftstrand Canadian crutches are preferred. Activities of daily living. A large variety of adaptive equipment is available to assist individuals with muscle weakness perform everyday tasks. However, the benefits and effectiveness of adaptive equipment for people with ALS have not been evaluated systematically. No one type of device is suitable for every patient or for every stage of the disease. Reimbursement for the equipment is variable, and although a piece of adaptive equipment can help the patient maintain independence, limited financial resources may prevent recommending or purchasing the item. For example, in the early stages of ALS, a universal cuff with a pocket for writing or feeding utensils may be beneficial. As the disease progresses and proximal shoulder weakness increases, a mobile arm support may be incorporated to allow the patient to maintain independence in eating. In the late stage of ALS, when the patient is dependent on the caregiver for eating, a long straw and straw holder may be recommended to assist the caregiver with the activity. Examples of adaptive equipment that may be beneficial for performing ADL are presented in Table 17.5. Decreased mobility. Patient with lower extremity weakness may have difficulty with sit to stand or car transfers. Simple interventions include placing a firm cushion 2 to 3 inches thick under the buttocks in the chair or elevating the chair by placing the legs in prefabricated blocks. Self powered lifting cushions are relatively inexpensive and portable, but the individual needs adequate trunk control and balance in order to use the device safely. Upholstered reclining chairs with powered seat lifts may also be recommended but are more expensive. All these interventions increase the biomechanical advantage and make it easier for the patient to rise from a sitting position. Caregivers will need to be educated regarding assisting in the patient with transitional movements. Transfer boards may be used for transfers once the individual is unable to stand, either alone if the person has adequate arm strength and good sitting balance, or the caregiver can be instructed in how to assist the patient. Other useful devices to assist patients' mobility are transfer belts and swivel cushions or seats. Transfer belts ease the burden of the transfer for the caregiver and prevent potential pulling on the patient's upper extremities. Swivel cushions are lightweight, cushioned seats that swivel in both directions and make getting in and out of car easier. Once an individual cannot perform transfers, even with the assistance of a caregiver, a hydraulic or mechanical lift is required. Commonly recommended lifts devices include the Easy Pivot and Hoyer lift. Use of an electric hospital bed may facilitate bed mobility and transfers both for the patient and caregiver, and depending on resources, Home modifications and automobile adaptations may also be considered. Prefabricated blocks, swivel cushion, uplift seat